as much of this stuff as we can in a reasonable period of time and complete this. This is somewhat busy work, but I think it's really important. I am a nut, a full-blown crazy person for epithelial tissue because of what we've learned. It's the most rapidly replaced tissue effectively in our body. And because of that, and because of things that are so easy to cause aberrations in our cell cycle, by a variety of different things, these are the ones that get cancerous the most, by far and away. So you really have to be, I think you have to be very, very knowledgeable. Skin cancer, glandular cancers, and sometimes we don't have explanations for why people get certain. There's just no rhyme or reason to it. You can think of environmental factors, but or not, that are involved, and so it's to a certain extent. And I realize it's a different context for young folks like you, because typically, unless cancer has touched you in a family sense or in a personal sense, I certainly hope it becomes much more relevant as you get older, because you hear more and more people with those problems that are there, and predictably some that you could imagine how they could avoid them. It's just it's something, and that's why I spend a fair amount of time about it, because if you're going to run into folks in your orbit, they are going to happen. Maybe, hopefully not your parents, grandparents, whatever, other people, older relatives, etc. Much more likely. Nevertheless, if you recall, we completed looking at these things. And again, for instance, when we learn about respiratory, the hallmark respiratory type of epithelia, pseudostratified, ciliated, columnar. Big problem with those when we destroy them, particularly with smoking. Okay, what's going to happen is it can't get rid of that mucus effectively. Those cilia are like they beat it towards your mouth, whether they're coming from your nose down towards your mouth. If they're in the oral area, they're out towards your mouth, or from the laryngeal area up towards your mouth, so we can expel it in some way, shape, or form. We expel it, we swallow it, whatever we do with it, it no longer creates the problem. And the trouble is, when those cells die, for whatever reason, or we accelerate their death and not that, or eliminate their likelihood of repair, it is much easier for things to be trapped in there, particularly viruses and bacteria. You're much more prone to respiratory infections, first upper and lower. When I was a heavy smoker, I have a cold that would last for a month. I'd be sitting there bringing up stuff in the middle of where I was treating patients or in the middle of clinic. It's disgusting. I didn't know it. My first wife used to say I smelled like a cigarette. I didn't realize that until I stopped. And there's nothing worse than a reform smoke. Nothing. Like, you smell it everywhere. You walk by, anywhere, and there's smoke. It's like that kind of thing. But it's okay. It's why I try to share that with you, so you understand where it is. Thankfully, there's less of that that's going on. Simple columnar is the hallmark epithelia of the gastrointestinal, particularly stomach, small, and large intestine. And again, the most rapidly replaced pretty much of all of those. Just to give you some ideas of where that is. So I think those are important points. And as I look through and we look at the first exam and where you're going to see this material, I'll make sure you're aware of the ones and the points to remember. I don't want to give it to you in a vacuum. This brings us, so those are the simples. Squamous. And again, as the cell gets more toward columnar, it gets busier. It has more, there's just more stuff it can do. More mitochondria, more organelles, more busy stuff. It's structure and function. Again, I hope the way I present it, one, makes sense to you, most importantly, and two, you find it somewhat interesting. But you guys are not overly reactive yet. It's not a knock. Okay. I need to see some. Humor me one time, ask a question. It's okay. I can pull Dr. Hillwig, say, go by the, so-and-so. I know. You're not Laura, you're Alyssa.
Oh my God. Okay, I didn't think you were going to
I have a sister too. She doesn't look a thing like me. I have a picture recently. She's tiny. She's gonna be 80 on October 9th. 5 years, 7 months, and 1 day, and 1 hour older than I am. Offhand. I bet you're closer in age.
Yeah,
Mm-hmm. Yeah, I'm telling you. See, my parents know. Once I came around, forget it. We can't do this again. And baby boomers, it was rare to have more than two. If you had a boy and a girl, basically, three was an odd number. My wife has has an older sister and then a brother. Brother's my age. Her sister's a year older or so, and so she's a little bit younger. My wife was born in '58. So I mean, there's not an enormous difference in our age, like 6.5 years, which may seem like a lot now, but it's not a lot. And there's nothing unusual about that. So which brings us to stratified, means layers. If you're making layers, think protection. The more layers, the more protection there is. So these are very common. We see two types: stratified squamous, and there are rare examples of stratified columnar and cuboidal. They are typically in like the tubular sections of glands that are going where the secretions are coming out. We don't see a lot of them. It's not a big deal. So I don't have reliable examples. But stratified squamous, it's all about your blood supply. Skin, as it goes away from its blood supply, because remember it's avascular, it dies and changes. And the composition of these is they begin when they die and they lose their blood supply. They gradually develop a protein inside called keratin. So, and that's a structural protein that why our skin is harsh, is strong, dry, water resistant, all of those good things that skin is. We do a whole unit on the skin, so you don't have to, we're going to incorporate all of that. All the other moist linings are stratified, all the entry points, whether it's orally, nasally, rectally, vaginally, pick an opening like that, stratified squamous non-keratinized. So it's really important. We typically call it mucosa or moist mucosa, mucous membrane. Not that it necessarily secretes a lot of mucus, as sort of a generic name that we often give it. So depending on the field you're going into, we might say, might look in the mouth and say, look at the mucous membranes. Well, there's probably more saliva and less mucus that you would typically find there. So mucosa and mucus are not necessarily interchangeable terms when you get to the clinical end of things. So 2 or more layers. Stratified could be just 2, or it could be 30 or 40, as you will see when you look at skin. The new cells, and it's like pushed up from below. So normally when you think of building something, we build it on top. Here's a layer of bricks. We put a layer on top of it and a layer on top of that. It's like, imagine that we laid these bricks, we put the layer down and we lifted them up, put the next layer. So it's undergoing mitosis, and the new layer is being pushed out at the bottom, and effectively the upper layers are being pushed farther away from the base, and it's through that base that they derive nutrition. So that's why they're moving. And so if you're moving away from your blood supply, it's going to change. The fact that it does not keratinize is because the blood supply is, for lack of a better way to express it, more abundant in those areas like your mouth, anally, vaginally, nasally, etc. So because it's about, and its protection, it is a big role. The most widespread of the stratified, even more so than skin, including skin rather, is stratified squamous epithelia. So the free surface, we define it by the outermost layer, the apicalmost layer. And another term would be the free surface, hence squamous. And it typically, where it's being mitotic, where the base layer is typically cuboidal or columnar. Really not a big deal. There's enough variation. To me, they look probably a little bit more cuboidal than columnar. I don't make a big deal out of that at all. That's there. And so wear and tear. Protection, protection, protection. That goes on. And then all the moist linings, as you can see, non-keratinized, will dedicate a whole thing to all the multiple layers of the skin. So here, let's say this is in the oral cavity. So here you can begin to see these base layers. So what happens, this is the connective tissue where it derives its blood supply. Here's the basement membrane, an actual microgram. And what happens, those cells are reproductive. They're typically in little mounds. And as they begin to move away from the blood supply, you can see the nuclei begin to flatten and flatten more until eventually they come. But you can see all the way to the surface. What this distinguishes, those are viable cells. They have a nucleus. And because of that, that's why when we do DNA sampling, all you need is some saliva. If this is a Q-tip, you could, a cotton tip applicator, put it in along the gums, take it out, pop it into a tube, and they can generate enough DNA to do, basically DNA profiling with that. That's why they're always looking for fluids. And all those police shows where they're running around getting stuff. If you sneeze and there's a tissue, they grab it. They want you to have a zillion things to drink so they can get the can. Let me throw that can away from you now. There'll be stuff on it. They're always looking for fluids, and particularly so, from a forensic standpoint, with sexual assault and things like that. So, that's so you can see it out to this layer that's there. Very easy to visualize. We will not go into the names of these layers. We'll save that for skin. But again, the fact that you see these flattened nuclei and the large amount of cytoplasm is where it derives its name. Squamous or squamous, doesn't matter. So esophagus, mouth, vaginally, keratinized forms the epidermis of the skin, which is drier. Areas which are drying out or are being traumatized will begin to keratinize. Bless you. And a lot of times we will see that in areas that have been damaged repetitively for whatever reason. So, for instance, I like if you're like me, it's not a secret, wear dentures, you're going to have, I get a callousing up there. So callousing is just overusing it. It increases the blood supply and it thickens the cell. Just the way you would get a callus on your hands. Okay? From some activity you do. Work with your hands repetitively. Or maybe you played a musical instrument and you play the guitar and you got calluses on the fingers that we were using. So callus is just overuse. Or excessive use. Overuse may be the wrong term. It reflects an area of usage. I hope it doesn't bug you that I share stuff about me. Because a lot of stuff's happened to me over the years. Whether it's cancer, whether it's gastrointestinal problems, the entry-level students keep been around the block already for a while. I feel strongly that if you don't share something about yourself, you're really not, you just don't generate, the relationship with students as effectively as you might. Not necessarily everybody appreciates it. If I say something you don't like or it's offensive, please tell me. I will not do it again. You're paying me. Somebody's paying me. Dad, a bunch of loans that you're going to have to pay back. Oh, won't that be fun? Whatever's happening, you tell me. Dr. Dress, you can't talk to him like that. You know how mean he is. Let's see. Nicest guy on the planet. He's definitely on the Mount Rushmore in that. Badger guy's mean. I don't remember seeing any of you guys fired in his office, sitting there trying to figure out, what this structure is or that structure is. All that wonderful nomenclature from organic. I took organic 1 and 2 in a summer at Seton Hall University in South Orange, New Jersey, where I eventually graduated from. 4 weeks each section. We went 8 to 11:30 in lecture every day, Monday through Friday, and we did lab from 8 to 12, and I think lab was 1 to 4:30. 4 weeks. And every night I went home and read, did problems, all that stuff. How's that? I think the guy's still alive. he must be pushing 100 years old. He was a professor emeritus by that time, very famous. That's for 2 months I'll never have back. They were just very entertaining. And then my best friend and I went cross country for 3 weeks, 3.5 weeks. You may have heard of that generation. They were called hippies. Look back in the history books. My hair was shorter than this. That's possible. His hair was longer than yours. It was like, remember John Lennon and the Abbey Road album? His hair's like that. Now his hair's short. Did all that stuff. Thankfully, the statute of limitations has run out. But I digress. So, cuboidal, rare glands, 2 layers. Same thing with columnar, rare. Male urethra, some glandular ducts. Typically, yeah, it's transitioning between other things. I don't get excited about that. So it's sufficiently rare. This one's important because it's where my cancer was. Transitional epithelia. We only find transitional epithelia in what's called the urinary tract. So it is of the bladder, it is of the ureters, and it is of the beginning part of the urethra in all of us. There is it's not entirely, it is probably 99% of the cases that individual has his history of cigarette smoking. For some reason, some of the carcinogens seem to accumulate in the urine. So it's not entire, but that's really underlying. It's some kind of, it could be pipe smoking, something, cigar smoking, whatever. The basal layers are, and it's really a misnomer. They call it transitional. Think of it this way. When your bladder is empty, okay, there's like 7 to 12 layers. When the bladder is empty, you see all 7 to 12. When the bladder or the ureters are full, the fluid alone pushes them down. It looks like 2 or 3. That's what they mean by transitional. It's not magically changing. It's just, it's an optical illusion, so to speak. It's like sometimes you see things under the microscope that are like that. Okay, they really aren't, it just appears to be there because of the way you're looking at them. So they change shape when stretched or for storage, that is there, and you'll see it. What gives it why, if you go back and look at stratified squamous, notice the squamous, notice the flattened cells, okay? If you look at it here, you see this is classic. The cells are rounded, the nuclei all the way to the top. They're rounded on top. That's when we know it is not been compressed down. But there's a lot of layers when you look at these different sections. So you can see, I'd say 7 to 12 on average. At least that's the way I learned. All of the ureters, all of the bladder, and typically the start of the urethra. So, and then in the male, there's probably a little bit more. In the female, because it's shorter, okay, it makes the transition to stratified squamous. As you get close to the outside, all of these openings begin to change to stratified squamous from if they were something else before that. It's just the nature of it. And so I had what was called TEP1, transitional epithelial type 1 cancer. So effectively, that means it was probably confined here and maybe just started to get into the connective tissue. That's the distinction. That's how, if you wonder how they determine cancer treatment, it's based on what the cancer looks like, how far it has spread into, whether it's gone to a lymph node, or in the case of bladder cancer, whether it's gotten to the muscle of the bladder. So there's a whole lot of things. Deion Sanders just had a bladder removed, or a partial bladder removed. Maybe you read about that. Okay. And I don't know that he was a smoker or not. I don't know. On occasion. I mean, for a world-class athlete in 2 sports, would probably unlikely, but who knows? It's been a long time removed. And maybe he's got diabetes because he's lost a couple of toes already. So I expect there's more than one health issue. I was fortunate that it was not, that it had not spread significantly enough that it required chemotherapy, okay, that they were able to utilize immunotherapy, which had its problems. That's when we get to the immune system, we'll talk about that. But they used basically Immunotherapy is a little bit more progressive in the sense you're trying to stimulate your immune system. But the trend now is to get away from chemo and radiation, because basically the whole sense of those, you hear me say it a lot, is we're basically bombarding it with deadly radiation and deadly chemicals in the hope that it'll kill the cancer cells before it kills the good cells or kills you. That's what chemo and radiation are. In a hospital, in the old days, we used to talk about chemotherapy, and chemotherapy is my blood pressure medicine is chemotherapy. Cancer chemotherapy, we used to call pushing poisons. It's just what they are. So, I mean, we're thankfully, as time has gone on, we're pushing that farther away. Glands are interesting. Okay, they make a secretion, and we classify these. We have a whole unit. This chapter focuses on exocrine. Exocrine means they have a duct. Endocrine are ductless. Your pancreas is a double duty gland. Your ovaries and testes are double duty glands. In that sense, they're both endocrine and exocrine. When the testes are making sperm, or the ovary is releasing an egg, it's releasing it into a duct, and that duct eventually gets it to wherever its destination, effectively to or close to the outside. And sperm outside in the egg, it goes into the oviducts. In perspiration, the liquid comes out by way of that duct, goes out to the external surface, to the skin. An endocrine would be the ovaries and the testes producing testosterone, progesterone, estrogen, or the pancreas producing glucagon and insulin. They go directly into the bloodstream. So they are inevitably glands, endocrine glands, whether they have one duty or both, are surrounded by a mass of blood vessels because they're like a sponge. It's like comes out of them like a sponge, and the blood vessels soak it up. So you'll know that when we do this brain dissection, you'll see the pituitary, you'll see a nodule of blood vessels that have hardened and surrounded. It'll be like a knot, like a lump of hard stuff. So we can't see the whole thing. We've got a sheet that are there. Your thyroid has an immense amount of blood vessels because it's so busy and so active. When you have to remove a thyroid, very, very difficult. It is so easy to get bleeding in that area and cause somebody to be unable to breathe post-operatively. Very, very significant. We'll look at that when we look at endocrine. We don't look at endocrine other than in passing in anatomy because it's much more of a physiological system. But exocrine is this. The goblet cell in columnar epithelia, whether pseudostratified or simple, is a unicellular gland. It's a unicellular exocrine gland. It makes mucus. All the other ones are multicellular because they have an area where it's produced and then it makes its way out. So voila, this is what I mean. You'll see some illustrations. So here, multicellular, these are the cells. Think of this as the duct. Inevitably, in the simplest of the exocrine glands, there's a widening of that duct. My artwork is terrible. I've decided not to do it. If I can possibly do it. And so it's being secreted here, and it works its way out. Usually there's some smooth muscle or related structures that facilitate that. Sometimes it's just production. It's got nowhere to go but out. In this case, it looks like it's going out to the surface. Endocrine, as you can see, there's a nest of capillaries around it. So again, this is the endocrines, exocytosis. We'll get into it. When we do that system, by definition, they travel typically through the bloodstream to target organs. And they have different, some have target organs all over. The thyroid hormone, nearly everything is a target. Okay, where if you look at, I'm trying to think of a very good example. Pardon me. So, okay, follicle stimulating hormone either goes to the testes or the ovaries and induces sperm production or the maturation of eggs. Very specific. Growth hormone everywhere. Exocrine glands, body surfaces or into the cavities directly, whole lot more of them. Okay, mucus perspiration, oils. At the base of every hair follicle, we have a sebaceous gland. It's an oil gland. Some of us, our hair is dry, some is oily. That's probably hereditarily based. We sometimes deal with that with either hair care products. We deal with skin that's overly oily with different products. When those get clogged, those sebaceous glands, they cause problems, not the least of which is acne. They get clogged, and there's a particular bacteria that will flourish in there. It's found on a lot of different skin. And so when we have an acne that flares up, it depends. And so there's different, and so a lot of the treatments are dedicated to that. We use a lot. Did you cover this in micro about acne and things like that? Or no? It used to be called propionic bacterium acnes, and used to like vitamin A acids. Like if you used, any of the commercial products are typically vitamin A acid that are used for that. And sometimes you use mega doses. That's that. Oh, I hate to get something. Accutane, which has a lot of side effects. My stepdaughter was on that stuff. I think she'll be 31, I think, this in September. But she was like 15 or 16. I mean, really bad. It really helped. It made it worse at first. It really helped. But before they would release the prescription, she had to go and get a blood test drawn to show she wasn't pregnant that day. And then and then up in Cranberry for Pacific North would contact. We used the Walmart. She used the Walmart there, and they released a prescription for that. That's how significant a risk it was. All sorts of stuff like that, plus other side effects that were involved. So there's different things. Salivary glands. So you're going to see it can be a single cell, like the goblet cell. That's really the only example. Everything else is multicellular. Again, respiratory and intestinal. Mucus again. Mucus, by definition, mucus is thicker, slimier, stickier. So it enhances the protective nature for whatever it is for. Maybe it's protecting linings in your stomach, where it incorporates an alkaline lining to fight off the stomach acid, or whether it's just sticky enough to pick up yuck that you're inhaling. And we are inhaling constantly. This is a very good illustration of it. So you have the nucleus. Look at all the end of it. You have an abundance of endoplasmic reticulum. Busy cells have a lot of rough endoplasmic reticulum. They're making proteins, and mostly proteins to be released. You can tell a lot about that. I mean, when cells that have a lot of smooth endoplasmic reticulum, like liver cells, do a lot of detoxification because that's usually done with smooth endoplasmic reticulum. So if you get into the cytology and histology of it, that's how pathologists are able to tell. If you didn't know, when they do certification, they'll flash up a slide of a tissue section or cell section. They have 30 seconds to make a diagnosis. Smartest guy I know, and he's probably still practicing, he's got to be pushing 80. Is a oncologist, pathologist. Sloan Kettering trained, went to Muhlenberg, graduated top of his class. Jefferson Medical School, Sloan Kettering fellow. And he did, I don't know if he's still, how much he's practicing now at Hackensack Memorial Hospital. It's a big teaching hospital in northern New Jersey, just outside New York City. This is story time. Imagine his mom and dad were my mom and dad's best friends. Both my mom and dad and his mom and dad never set foot in college. My dad started in college, and then the Depression hit, 1931. My mom never went to college. His mom and my mom were best friends, are you ready? For the better part of 80 years. What's that? When they were in 6th grade together. And all of their children, I flatter myself, were smart. This guy was the smartest of the lot. So every so often I've had cases where I was in practice, and even a student here came to see me, and unfortunately, because he and his friend came, it was about a girlfriend who had gotten a very sad diagnosis. They wound up, and it was very sad. So I got in touch with this guy about that. So he's like my source for it. Amazing. I always wonder how, if it would have made a big difference. They'd had the luxury of going to school, but it was a depression. There wasn't a whole lot of money. They graduated high school together in 1936, my mom. So, multicellular exocrine glands, ducts, and usually there's a central duct, but there's other ducts, as you will see. Lots of supportive tissue, and this is what I don't do. The structure. The mode of secretion is important. So the structure, simple, whether it's branched or compound, meaning it's branched, I'm going to ask you to do this, tubular and alveolar, tubular where they're relatively straight, alveolar collects it from, and there's combinations. Look at this, drive you nuts. Medical school anatomy, if you're interested. Okay, simple. Glands in the gut are relatively simple, or it can be a little more complicated, or more complicated still. You can see as you get into the stomach, the duodenal area and the small intestine is very, very busy. Okay, here's sebaceous glands. Okay, here are mammary glands and salivary glands. So you can get a look at the different types. You don't have to know them. I'm not going to give you a chart. I'm not going to put an illustration and say which one is this. I'm trying to give you an idea how they classify them anatomically, structurally. So there's not a lot to say about that. This is more important, how they are secreted. So secretions, merocrine, and sometimes they'll be eccrine, in other words, ECCRINE you may run into. And that's the equivalent of merocrine. And the best example is perspiration. You draw a simple glandular structure, and the cells, typically the cells are cuboidal in nature. Effectively, all they're doing is secreting a liquid. And the liquid has some electrolytes and maybe some waste products, even some chemicals that are useful, antibacterial in nature. Okay, there's a lot of stuff that comes out in perspiration. Pancreas, obviously, a lot more specific. Pancreas, when we get to it, digestive has more to do with what they collectively call digestive juices, which have enzymes in them. They have a fair amount of bicarbonate because the pancreas secretes, because it changes from digestion. Your stomach is an acid environment. Your small intestine is an alkaline environment. Your stomach's governed by pH. Like, yes, it turns on the stomach. Alkalinity or basicity turns on the small. That's why that's important. It just comes this way and it comes out. Whatever the surface is, let's say it's the skin. That's a typical merocrine or eccrine. Sometimes they get clogged. Okay, we'll see different. We'll even see a cyst form. We'll talk about, I've taken out eccrine cysts in the skin. Sometimes they form a lot. I can't tell you why exactly. Holocrine is easy. Apocrine is the other. Holocrine, think of the whole cell. So what happens is these cells form and they begin to replicate. So this epithelium is very microscopic. A whole cell will come and deteriorate. You're secreting the whole cell. The whole cell, because there's a substantial amount of membrane, creates oil. That's classic for sebaceous. Oh yes. Holocrine. The oddball is apocrine. It's a little both. Because remember, the epithelial cells have a basal portion and an apical. So what you have here, the whole cell, what happens is little pieces of the apex. That's sort of a mixture between more serous, more like perspiration, and oil. So they're a little bit more oily, but not nearly as liquid as they are over here. There are some authors who think that these don't exist. I'm not one of them. Typically, we see apocrine glands in the groin and in the axilla, and a lot of us think that mammary glands, when they're active during lactation, are apocrine glands. And I'm one of those people who subscribe to this. We seem to see the onset of these during puberty. And, and a lot of, and the distinctive odors that are associated that little kids don't get other than from just bad hygiene, that we see with the onset of puberty, we think are responsible from those kind of apocrine glands that show up at puberty. And they're typically associated in the same area where pubic hair and secondary sexual development. So they're associated in the same area as sebaceous. So you have both sebaceous and apocrine associated with those areas. It's pretty interesting. So the apex ruptures is what they're saying there. And whether this type exists in humans is controversial. Maybe to them, not to me. Just bless you. What are you going to do with you? If you're two sneezes and back during COVID, they would have had you stupid masks. You guys ought to have to put up all that in high school, right? Didn't you? Oh dear God. That's happy dance. One down, one to go. We're just going to get an introduction. I don't have a lot of time. You'll be happy to know. We'll introduce connective tissues. Hello, I'm a connective tissue. Nice to meet you. Con mucho gusto. El gusto es mío. When you learned that in Spanish, your first day. Hola, ¿qué tal? ¿Cómo se llama usted? I love it. My eldest is so good at that. When we go out, to a Mexican restaurant or that, he can talk to everybody there. He got in the Navy. He was in San Diego. He wasn't that busy to start because the ship was in port. So he started just, to do so was tutoring kids where English was a second language. I don't know how he would tutor. He's not that bright. How he got where he is. He has never set foot in a science laboratory. For graduating with a degree in political science from Duquesne. Go figure. The only science course he took was physics, and he didn't have to do the laboratory. He took calculus a couple of times because he had to repeat it. Moving on. So we got more connective tissue than anything else. Connective tissue, as the name would suggest, binds, protects, insulate fats, a connective tissue, storing fuel, fat. Blood's a connective tissue. When we hear the term tissue, we think solid. There's nothing in the books that says it has to be solid. Connective tissues can be solid, they can be dense, they can be loose, they can be liquid. It all depends on their composition. So you're going to see the ones we're going to deal with here. Blood is a separate unit unto itself. Bone is a separate unit unto itself. Well, they are still classified as connective tissues. We're going to spend more time on connective tissue proper and cartilage than anything else. This classification is very useful. And we're going to go ahead for a second. All connective tissues. These are the three components. Cells, and those cells, the principal cell, it's not the only cell necessarily in a connective tissue, but the main cell secretes something called a ground substance. And again, that could be liquid in the case of the blood. That could become solid in the case of the bone, or it could be semi-solid in the case of cartilage, or varying degrees of soft or dense, depending on the amount of fibers, and it secretes fibers. So as long as it's making fibers and making ground substance, the fibers and the ground substance come together, and we frequently refer to them as the matrix. And they have some type of a cell. That's the requirements to be a connective tissue. Because people often misunderstand. Okay, it's about, and I agree, composition and arrangement and these various elements considerably. If you have a ton of fibers and very little ground substance, you might have something that is all about tensile strength, a tendon or a ligament. And you're going to see, just like in epithelial cells, just like in other things, there's good news and bad news. The good news is it's strong, it's hard, a tendon or a ligament. The difference is probably a degree of elastic tissue that the ligaments have. There's bad news. If they tear, there's very little blood supply. Without blood supply, you can't. They're going to heal with scar tissue. The old days, when I started back, I was a resident, orthopedic resident from 77 to 79, is the early onset of arthroscopy. We used a straight scope merely to look inside, and basically you end up opening up the knee and sewing the ligaments together. Okay, grafting, or whether it's cadaveric grafts or autografts, doing surgery by way of or through the scope, which is almost entirely done today for knees, which is in its absolute infancy. Because most everybody knows somebody who's had some kind of knee procedures done. I've had one back in '85. I had a bucket handle tear of my right meniscus. So, I mean, it's fascinating, all of these things. So you're going to see the variations, and you're going to see the microscopy of the variations, which I think is fascinating. So we work our way back. I use the same category, and we all do. 3, 3, and 3. It's easy in that regard. You have loose. It's loose because it's not filled with fibers. There's space. The question is, what's the space filled with? So you're going to see loose, meaning their fibers are not as densely packed. Okay, so you have room for other kinds of cells. You have some fat in there. The ground substance, you have 3 different major kinds of fibers you will see. The 3 fibers are called collagen, it's the thickest and the most abundant. Elastin, okay, which is not quite as thick, but just as his name would suggest, it's stretchy. And then reticular, which are thin collagen fibers that are coated. And the best analogy for them is they act kind of like a sieve, a strainer, like a fine mesh strainer. Got all those grounds in the coffee and the tea, you got to pass it through something. Does anybody have, are you familiar with that room with the burners and the refrigerator, the kitchen? I have to have cooking class. That's all right. We got pizza last night. There's still some left over. That's going to be for tonight. This place by us makes a steak and ranch pizza that is to die for. I have somewhat of authority on this. So dense connective tissue, just that. It's dense. Thick stuff. And again, no blood supply. That's what you're looking at here. That's what a tendon would look like. We'll talk about the parallel nature of the fibers. And it can be regular, a regular arrangement, an irregular arrangement, or one that's just filled with elastic tissue. Really important when we get to the physiology of how the heart works. There's special arteries that are all elastic tissue, like the aorta, like the carotids, because they rebound. They're like a trampoline. So again, structure and function. Cartilage, 3 different types. Okay, most abundant by far is hyaline cartilage. Nearly every one of your bones comes from originally being cartilaginous. Many of them are cartilaginous when you're born. It doesn't mean that there's some flexibility that's there. Elastic cartilage you only have in 2 places. Your ear, okay, and your epiglottis. Those are easy to remember. Always a test question type stuff. Where are the two places with that? Anytime you have one of those, it's slam dunk. It's like what the nucleolus, remember that? In the cell, what does it do? It makes ribosomal RNA. That's what, I'll put it on. I'm giving you a test question for the first test. You don't have to thank me. And again, Venmo at Dr. Badger, that a-hole, and fibrocartilage. I'll tell you where that was. Enough of my bad jokes. Goodbye. You don't want to hear them anymore either. Neither do I.